Welcome to the Deep Dive. We're the show that helps you cut through all that information noise, get right to the heart of complex topics, and hopefully find some clarity, some compelling insights so you can feel truly well-informed. Today we're diving deep into a really fascinating medical study. Actually, it's one you, our listener, pointed us towards. It's a published paper from the Lung Cancer Journal, and it details something called the EDEN trial. Right. So our mission today is really to explore this question. When it comes to advanced cancer treatments, specifically a type of immunotherapy called Nivolumab for squamous non-small cell lung cancer, that's SQNSCLC, is earlier always better?
Yeah, and what's really interesting, I think, is that this study tackles a question that was super relevant maybe just a few years back. But honestly, the implications for how we think about treatment strategy, they're still surprisingly relevant today. It's kind of a unique snapshot, almost historical, because it was designed before some of the current standard practices were even in place. But it still gives us, well, some really thought-provoking stuff to consider now.
Okay, right, let's unpack that. To really get the EDEN trial, we need to set the scene a bit. Before these immune checkpoint inhibitors, ICPIs, like Nivolumab, these are the drugs that kind of wake up the immune system to fight the cancer. Before they were common for first-line treatment, what was the standard approach for advanced SQ-NSCLC? And, what were the big problems?
Well, before ICPIs really took hold for first line, the standard was platinum-based chemotherapy. And frankly, the outcomes were pretty disappointing. We're talking median overall survival, so how long patients lived on average, around only 9 to 12 months. And a really critical issue back then was that a lot of patients, maybe around 30% historically, they decline quite quickly after that first chemo. They've become too sick, basically, to even get potentially helpful second-line treatments. It was a major concern.
Wow. Okay. So a tough situation, not many good options after that first line failed.
No.
And that's where Nivolumab made a splash, wasn't it?
Exactly. The Checkmate 017 trial in 2015, that was a huge breakthrough. It clearly showed Nivolumab was better than another drug, docetaxel, but specifically as a second-line treatment for this type of lung cancer. It made a massive difference. Median overall survival jumped from 6 months to over 9 months. That trial pretty much established Nivolumab as a new standard for second-line therapy almost overnight.
So with that kind of success in the second line, it makes sense people started thinking, what if we used it even earlier? Was that the basic idea driving the EDEN trial?
Precisely. That was the core hypothesis. Could using Nivolumab sooner as what they called early switch maintenance, right after finishing that first-line chemo, could that lead to even better survival? The thinking was, maybe we could ensure more patients actually get the drug and benefit from it, especially since back then, nobody had really tested ICPIs as switch maintenance in this specific cancer type.
Got it. So that brings us to the EDEN trial itself. GOIRC-04-2016, that's the official name. Tell us a bit about the nuts and bolts. How was it set up?
Sure. So EDEN was what we call an open-label, two-arm phase 3 study. Open-label just means both patients and doctors knew what treatment was being given. They enrolled patients with advanced SQ-NSCLC, stage IB Viver, or recurrent disease who had finished their initial 4-6 cycles of platinum chemo. And crucially, their cancer hadn't gotten worse during that chemo.
Okay, so patients who had at least stabilized on chemo, and the two arms, how did they compare the strategies?
Right, two groups. Arm A was the experimental arm. They got Nivolumab straight away as that early switch maintenance. The dose was 240 milligrams intravenously every 2 weeks. Arm B was the control arm. They got standard best supportive care, basically managing symptoms. Nivolumab was held back. It was delayed until their disease actually progressed. Then they got it as their second-line treatment.
And the main goal was to compare overall survival between giving it early versus delaying it.
Exactly. That was the primary objective, overall survival. And in both arms, if they got Nivolumab, they could continue for up to 2 years unless their disease progressed or the side effects became too much.
Now, you mentioned the study hit a snag. It didn't actually finish enrolling everyone it planned to, did it? What happened there?
That's right. It didn't run its full course. They aimed for 388 patients, but it was stopped early. Only 125 patients were actually randomized across, I think, 32 centers in Italy between late 2017 and mid-2020. And the reason it stopped early was, well, a major shift in the field. Other studies showed ICPIs worked in the first-line setting for SQ-NSCLC, and they got approved for that use. So suddenly, the ethical landscape changed. It became clear that for many patients, potentially withholding Nivolumab until second line, like an Arm B, might not be the best approach anymore. Continuing the trial as designed just wasn't ethically feasible.
Right, a classic example of how fast oncology can move. So, okay, with the 125 patients they did enroll, what did they find? What were these patients like?
While the patient characteristics were pretty typical for this group, and importantly, they were well balanced between Arm A and Arm B. Median age was 71, mostly men, about 79%. A vast majority were smokers or ex-smokers, around 94%. Most had stage IV disease, about three-quarters. And they were generally quite fit, almost all, 98%, had an ECOG performance status of 0 or 1. That basically means they were fully active or only slightly restricted in their daily activities. Very fit group overall.
Okay, fit patients. So the big question, the primary endpoint, overall survival, what was the result? Early versus delayed nivolumab.
Yeah, the main finding. In Arm A, the early Nivo group, median overall survival was 14.9 months. In Arm B, the delayed Nivo group, it was 18.8 months.
Wait, 18.8 in the delayed arms, so higher in the group that waited.
Numerically higher, yes. But here's the crucial part. The study found no statistically significant improvement in overall survival with the early nivolumab strategy compared to delaying it. The key value was 0.659.
So statistically speaking, no benefit to giving it early in terms of living longer overall. That is surprising. What about progression-free survival, PFS? Did it at least delay the cancer growing? Sometimes you see a difference there.
Ah, yes. And that's where it gets really interesting. A classic example of trial complexity. When they looked at PFS, the time until the cancer progressed or the patient passed away, there was a significant difference. In Arm A, the early group, median PFS was 4.5 months. But in Arm B, the delayed group, it was only 1.9 months.
Okay, so a definite benefit there.
Absolutely. Early nivolumab did significantly prolong PFS. The risk of progression or death was cut in half, basically a hazard ratio of 0.50, and the p-value was less than 0.001, highly statistically significant.
So it clearly delayed progression, but didn't help people live longer overall. That's the puzzle. Any other findings? What about safety?
They looked at a few other things. PFS measured from the start of the initial chemo was also longer for the early Nivo arm, but time to treatment failure and overall survival measured from induction chemo, no significant differences there either. Safety-wise, things looked pretty similar between the groups. Serious adverse events, grade 3 or 4, were maybe slightly higher in the delayed arm, 15% versus 10% in the early arm. Common side effects were things like fatigue, joint pain, appetite loss, fever, typical for immunotherapy. Importantly, no treatment-related deaths were reported.
Okay, let's circle back to that main puzzle then. If early nivolumab clearly kept the cancer stable for longer, significantly longer PFS, why on earth didn't that translate into better overall survival? What are the theories?
It's a great question, and the paper offers a couple of key potential explanations. One really important factor is that in the delayed arm, Arm B, a very high percentage of patients, 85% of them did eventually get nivolumab or some other treatment when their disease progressed.
So most of them got the drug eventually anyway.
Exactly. And the authors note that 85% crossover is actually higher than you might typically see in routine clinical practice outside of a trial. So this high rate of getting effective later line therapy in the control group could have, muddied the waters for the overall survival comparison. It kind of leveled the playing field later on. Another thought is that maybe these immunotherapy drugs, ICPIs, they might just retain a good chunk of their effectiveness even when used later. Perhaps the timing isn't quite as critical for OS as it might be for, say, traditional chemotherapy.
That makes sense. And speaking of effectiveness, the paper points out something else quite striking comparing Eden to that original Checkmate 01 scene trial. The survival in Eden's delayed arm was way better, wasn't it?
Yes, that's a fantastic point. Remember, the median OS in the delayed arm of Eden, where Nivo was given second line, was 18.8 months. In Checkmate 017, where Nivo was also given second line, the median OS was only 9.2 months, almost double.
Why such a huge difference for the same drug in the same line of therapy?
It really comes down to patient selection, fundamentally. The Eden patients were, by definition, a healthier group. They had to have not progressed on first-line chemo just to get into the trial. And as we mentioned, their performance status was much better. 60% were ECOG 0 fully active, compared to only 20% in Checkmate 01 scene. It's a stark reminder that the condition of the patient receiving the treatment heavily influences the outcome. Fitter patients often do better regardless of the specific timing sometimes.
And interestingly, the Eden patients were older on average, 71 versus 62 in Checkmate 017.
Right, which kind of reinforces the idea that age itself isn't necessarily a barrier to benefiting from immunotherapy, which is, good news.
Now, the paper also floated a more biological idea, kind of speculative, about why early Nivo didn't win on OS. Something about the chemo beforehand.
Yes, that's a really interesting hypothesis. They suggest that maybe the induction chemotherapy itself, the chemo given just before the nivolumab in the early arm, might have had an immunosuppressive effect. So giving the immunotherapy immediately after might have actually dampened the potential immune response, making it less effective than if it was given later, after the immune system had potentially recovered a bit. It hints at the complex interplay between chemo and immunotherapy timing.
So even though the specific question Eden asked, early maintenance versus delayed second line, Nivo isn't the burning question today because ICPIs are now used first line.
Right, the landscape has shifted.
The trial still gives us some real food for thought, doesn't it? It's a fascinating look back, but with lessons that still apply.
Absolutely. If you're going to zoom out, Eden really underscores that we still need to figure out the optimal duration of treatment with these ICPIs and exactly what role maintenance or consolidation therapy should play, even in the current first-line setting. The paper mentions another trial, Checkmate 153, which looked at continuing nivolumab versus stopping after a year. It suggested continuing longer might be better. So it just highlights that figuring out how long to give these powerful drugs is still a major ongoing question in oncology, often without a clear biological answer yet.
Okay, so let's try and synthesize the key takeaway for you, our listener, from this deep dive into the Eden trial. Basically, for this group of advanced SQ-NSCLC patients who hadn't progressed on initial chemo, giving nivolumab right away as maintenance didn't actually help them live longer overall compared to waiting and giving it when the disease progressed, even though, importantly, it did delay that progression significantly.
Precisely. And while, yes, today ICPIs are typically used first line, often with chemo, this study still gives us really valuable insights. Insights into treatment timing nuances, how crucial patient selection is for outcomes, and just how complex the interactions between different therapies can be.
So wrapping up, maybe here's a final thought for you to consider, something to mull over. We saw that healthier patients might benefit more, maybe regardless of timing, and we know the ideal duration of immunotherapy is still a big unknown. So how should future research be designed? How can we balance intervening early against potentially overtreating, ensuring we maximize not just survival, but also long-term benefit, and crucially, a patient's quality of life? Something to think about.